Hello everybody, this is Venk with Always On EM. Thanks so much for tuning in to our YouTube channel. I'm with Brandon here at ACEP in Las Vegas. I'm really excited to hear more about your work. Brandon, can you share with us about who you are and then about your work?
Hi guys, I'm Brandon Phong. I'm one of the third-year residents at St. Joseph's Medical Center, and my presentation today is about I wanted to create a simulation-based peritonsillar abscess drainage model that had the ultrasound capability incorporated into it. So for me, my very first procedure in the ED was a PTA drainage, and I'm gonna be honest with you, it was unsuccessful. And it was scary.
They're hard.
Yeah, you're jabbing a needle into the back of somebody's throat, and you kind of know the anatomy, but you don't have the experience. So it's a very daunting procedure. It was unsuccessful, and I kept thinking to myself, what can I do to increase the likelihood of being successful the next time? So I thought about, why don't we use ultrasound? It's quick, it's fast, it's low risk, and it could give us good visualization, and it would help junior learners a lot better. So I decided to create this peritonsillar abscess drainage model. And what I did was, the model cost around $8 itself. I repurposed a lot of equipment from our sim lab. So we repurposed a Halloween mask, we have a C-collar, a laryngeal airway model, which comes with every airway set that you have, a styrofoam ring that costs 20 cents, and I repurposed this foam headset that comes with the recessed anti-boxes. And regarding the PTA cup itself, it's a Dixie cup with a long balloon that I filled in with water and red food dye, and a water balloon that I filled with honey-colored soap and some water to recreate the abscess-like material. And this is my carotid artery that I'm simulating. And for my ultrasound components, I used Knox gelatin and psyllium husk, and it created a really great ultrasoundable medium. And you can see here, that is our abscess, our PTA, and that is our carotid artery here. So essentially,
are you scanning from outside the model or
from inside?
From intraoral?
Yeah, intraoral.
And so using an endocavitary transducer, or?
Theoretically, but unfortunately in our sim lab we didn't have any endocavitary probes, so we had to use the wide linear probe.
Okay.
Which I'll kind of elaborate more on on some of the difficulties that brought up.
Sure.
But essentially, I wanted to compare two groups, the ultrasound guide group versus the blind group.
Yeah.
It was run during one of my didactics. I split the two groups, 15 residents, between PGYs 1 to 3 and some off-service residents as well. Each individual session had 5 minutes total for each learner. And I ran qualitative pre and post surveys and a quantitative intervention survey. And these are some of the components. You can see here for your qualitative studies is like indications for drainage, contraindications, comfort level, usefulness of this procedure, usefulness for on-shift application. And right after they complete the sim session, quantitatively you measure how much they aspirated, the time that it took, the number of aspiration attempts, and the carotid artery puncture, whether they hit it or not. And ultimately, these were our results. So from the qualitative perspective, you can tell here, everybody, not very many people felt comfortable with this procedure, but after they completed the sim session, between the blind and the ultrasound group, a lot of people grew in comfort. A lot of people felt that this was a useful procedure as a procedure model and for on-shift application. And this was our quantitative data. Comparing the blind and the ultrasound group, the blind group hit the carotid 14% of the time versus 0% with the ultrasound group. Blind group had more drain attempts, which kind of makes sense because they're blindly poking around. They drained faster. They had shorter drainage times because they're poking, they're not using an ultrasound. But they were technically less successful in terms of their overall drainage compared to the ultrasound group. Unfortunately, some of the data is a little bit skewed here because not everybody completed their surveys, which tampers with the data. And you put all the hard work in, you generate the QR codes, and people don't even scan the QR code to fill it out, which is a little frustrating sometimes.
Shame on your colleagues.
Which is a little frustrating.
I'm kidding, obviously kidding.
But ultimately, the ultrasound group had more successful drains, less attempts, and no carotid artery puncture. There's some confounding information, study confounders, such as people not completing the surveys. I didn't know, but my sim director was leading the blind group. I was teaching the ultrasound guided group. He was actually using a 10 ml syringe, and I was using a 5 ml syringe, which kind of affects the length and ease of draining because you're not kind of fitting into a small surface area. And we were using the wide linear probe when we ultimately should have been using an endocavitary probe. I'd actually recreated this study using the endocavitary probe, and it was way easier to drain. So I feel like that would affect my overall data ultimately. My future directions for this, hopefully this kind of picks up traction, can reduce ENT consults, reduce CT imaging, reduce return visits, and decrease the length of stay in the ED ultimately.
Well, this is really interesting, Brandon, especially, I didn't introduce, but I'm an ultrasound fellow trained individual. I was the director of emergency ultrasound for Mayo for
Awesome.
many years, and so I've always found that PTA drainage with ultrasound guidance can be quite challenging at times, especially fitting a lot of stuff in the mouth and whatnot. So very, very interesting. Thank you so much for taking the time to share this. I hope you have a great time here out in Vegas.
Absolutely. Thank you so much.